Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi, everyone. Welcome to the Egg Whisperer Show. I'm Dr. Amy, your host, and I'm so excited to have a special invited guest, Dr. Laura Londra. Hi, Dr. Londra.
Hi, Amy. How are you?
I'm doing great. Dr. Londra is coming to us all the way from Columbus, Ohio, and there's no better expert to talk to us about this topic that I get so many questions about, and the topic is everything you should know about ectopic pregnancy. But before we start, I want to tell you guys a little bit about her and read her bio. So she completed a subspecialty fellowship in reproductive endocrinology and infertility at Johns Hopkins University, where her clinical research focused on factors affecting pregnancy outcome after IVF. She also studied the ethical issues related to reproductive medicine, and we're going to have her on another show to talk to us about that as well. Before her fellowship, she attended Wayne State University in Detroit, where she did her residency, and she's board certified in both OBGYN and reproductive endocrinology and infertility. Thank you, Dr. Londra. Why don't you just tell us a little bit about yourself too, and about your practice? Where's your practice? We want to learn more. Our audience members would love to learn where you practice.
Well, the first thing that you're going to notice about me is that I have an accent, because I'm originally from Argentina, from South America. So I still keep a little bit of that accent. But so I came here after finishing medical school there. And as you mentioned, I did my residency, fellowship, specialty. And then I came here we decided to start my practice in Columbus, Ohio. And so far it has worked out really well. It's a practice that is affiliated with Ohio State University, which is, as you know, one of the largest state universities in the country. So we do a little bit of teaching with the residents, a lot of practice with a large population of patients, and we are 4 partners, and we are very, very happy. It's a well-established practice, and I joined them 5 years ago.
Awesome. And what made you go into medicine, and more specifically, fertility medicine?
Well, this sounds like an interview.
It is.
Medical school interview.
It just you just feel more connected, and of course you're going to tell us everything about ectopic, but tell us more.
Yes. So there's no physicians in my family. I actually realized that I would love to be a physician, mainly because of the experience that my mother and my family had with our OBGYN. So the personal story about this is like when I was a teenager, and it sounds like I was a little slow in meeting some milestones, and my mom decided to consult with the OBGYN who had delivered me. And so I saw the way he worked, and I just loved it. The respect that he had from my family, and how much my mom trusted him, and I did too. And so then after medical school, it always seemed like OBGYN was what I felt most comfortable. And then REI was an easy choice, really, because I liked a little bit of surgery. I liked a lot about hormones. And of course, IVF is what I love the most. And so here I am.
Yeah, great. Well, let's talk more about ectopic. First question, what is an ectopic pregnancy?
Well, an ectopic pregnancy is essentially a pregnancy that implants in outside the uterus, right? The most normal spot where the pregnancy should implant is at the top of the uterus, what we call the fundus. And sometimes pregnancies will implant in other structures, most commonly in the fallopian tubes, which are those structures that are at the sides of the uterus, and that's so important for reproduction. But when a pregnancy implants in there, it can be dangerous and life-threatening. And so sometimes, a very low number of cases, ectopic pregnancies can occur in the lower portion of the uterus, which are cervical pregnancies, sometimes in between the uterus and the fallopian tube, sometimes even in the ovaries, and those are much, much less common. But the ectopic pregnancy that occurs in the fallopian tubes is the most common, and is unfortunately a non-viable pregnancy.
Yeah. And then how are they diagnosed? How would you know you have one?
Well, sometimes you can tell that something is not completely right by the levels of the hormone of pregnancy. When your OBGYN or your doctor is measuring the levels, then the increase is not appropriate, but that doesn't always happen. In general, the diagnosis is made with the lab results of the hormone of pregnancy, what we call the quant, and the ultrasound. And very often is several of these, several lab tests, several ultrasounds. It's not always straightforward, the diagnosis. It's not always that patients present and we know immediately that is an ectopic pregnancy. So that's also the difficult part of it, and particularly for us, because we monitor pregnancies really early. And so it's good in that regard that we tend to see things early, but at the same time requires frequent monitoring.
Right. I mean, you and I have very few emergencies in the middle of the night. Obviously, for our patients and for us, a period sometimes does seem like an emergency, but an ectopic for sure is one of the few emergencies that we deal with. So that's why we always want to make sure that we're diagnosing an ectopic pregnancy before it turns into an emergency. So let's say you've diagnosed someone, that you have a high index of suspicion that they have one. What kind of treatment options are out there for women?
Well, the treatment of ectopic pregnancy, as you know, has changed a lot. In recent years, in recent decades, the treatment has sort of shifted from being mainly surgery, the first option, to being a medical treatment. So in the past, patients would present as an emergency with pain and bleeding, and as a really life-threatening emergency. In our environment, this tends to be, yes, it's an emergency, it's something that is very much time sensitive, even if the patient is not in the emergency room. But we have two types of treatment. And the one that we most commonly end up doing is a medical treatment with a medication called methotrexate, which helps sort of, the way I explain to patients, it helps dissolve those cells and it helps resolve the issue. But sometimes we do have to do a laparoscopy and have surgery available, and sometimes that's the best treatment too.
And are there any women who might have a higher risk of ectopic pregnancy? What in general are some of those risk factors, if there are any? Well,
the main risk factors are always having any previous history of problems in the fallopian tubes, having had an infection, chlamydia, or any sort of pelvic inflammation. Also, there are some other conditions such as endometriosis that sometimes can cause scar tissues surrounding the structures, the fallopian tubes and the ovaries, and that could also be a factor. Smoking, of course, is a risk factor. I just have to say, most of our patients don't smoke because they know already that is not good for reproductive outcomes, but smoking is a risk factor. And patients who are undergoing infertility treatments are also in the group of patients that have oftentimes a higher risk of having an ectopic pregnancy.
Yeah, and why is that? What is it about fertility treatments that might give them a higher risk?
Well, it's mainly because some of the risk factors for infertility are also risk factors for ectopic pregnancy. In addition to that, there seems to be some influence of certain hormonal levels or hormonal levels, a balance between estrogens and progesterone. And so that sometimes can be a factor. And so even women who have perfectly normal fallopian tubes, they never had any issue, they don't smoke, and they could still have an ectopic pregnancy. And this is the part when there are so many unknowns about why this happens. Right. But it does.
Yeah. And then what advice would you give to someone who's worried that they have a tubal blockage before they even try and get pregnant? Like if they have one of the risk factors that you mentioned, is there something that they could do to learn more about their fallopian tubes first?
Well, usually we, as part of the infertility evaluation, or if there is any concern based on previous history that there could be a problem, the best test, the one I like the most, is the good old hysterosalpingogram, because that gives you a good view of the fallopian tubes, the shape of the uterus. It's that's the best way of looking into that. Sometimes if you have to have a laparoscopy for any reason, for an ovarian cyst or for pelvic pain, and you are trying to conceive too, it's a good idea to ask the surgeon to say, hey, can you please check my fallopian tubes? And usually we're able to pass a contrast, and we see the fallopian tubes patency. So we call it chromatubation, but it's a good assessment of fallopian tubes.
Yeah. And then let's say you have a patient who's had an ectopic, regardless of whether it was medically treated or surgically treated. How would you counsel her about her risk of having another one in the remaining tube?
Well, when you have had an ectopic pregnancy, of course, if you compare yourself with another person who didn't have an ectopic pregnancy, well, statistically speaking, yes, you have a higher risk of having another ectopic pregnancy, but overall, it's still a low risk. Thank God. So ectopic pregnancy is one of those things that happen infrequently. It's about 1 to 2% of all pregnancies ends up being an ectopic. So it's a low risk, but yes, you have a higher risk of having an ectopic pregnancy. But I always tell patients, even with that higher risk, you still your highest chances are of having an intrauterine pregnancy, normal pregnancy. Right. But the main thing is to check for those levels. As soon as you get the positive home pregnancy test, you call your OBGYN, you call your doctor, and they will order a quant, and then following the quants, and then precautions. If you have any pain, if you have any bleeding, do an early ultrasound. And as soon as we are able to see that little sac at 5 weeks or something, is really reassuring, because then we know, okay, we know there's a pregnancy in the uterus.
Right. So super important to call your OB ahead of time, remind them that you have a history of ectopic, and request early pregnancy monitoring. I mean, you and I, this is what we do, but a lot of OBs in the area, they may not see patients until they're 8 to 10 weeks pregnant, and that could be too late to diagnose an ectopic.
Exactly. And that's very important, because the sooner you know, the least invasive the treatment you can do, and the most success you're going to have at treating that pregnancy with medical treatment and avoid a procedure, a surgery. So yeah.
So I'd love to talk about some of the research you've done. You're very well published, and you published a beautiful study on ectopic pregnancy after IVF. Can you talk to us a little bit about your study and what you found?
Sure. Well, that was a study that we did using the, well, I don't know if all patients are aware of this, but in IVF, all IVF cycles are reported at the national level. So there's a huge database that collects information about cycles, about patients' characteristics, and what has been the outcome of those pregnancies and what treatment was done. So that is really, really helpful when we are trying to look for something that is really infrequent, right? So that was what we seem to be the most useful way of looking at this problem. And there's no animal models where we can study ectopic pregnancy. And so it's really hard to see ways of knowing more about this. But we did a study where we look at several years worth of IVF cycles, and we look at all the pregnancies, and we look at more than 100,000 pregnancies, and we look at the characteristics, and we analyze what has been the outcome when we transfer an embryo in what we call a fresh cycle. So we retrieve the eggs, we create the embryos, and we transfer them in the same cycle, compared to when we transfer the embryos that have been already frozen, and we just prepare the lining of the uterus only for that embryo transfer. And so we have seen in previous studies, because every study, takes it on based on other findings, and we have seen that this could be the case, that there would be a difference. But we decided to test this hypothesis in this large number of cases of pregnancies, and we did find a difference. So we found that there were more ectopics during the fresh embryo transfers compared with the frozen transfers or with donor cycle transfers, which speaks to the possibility of these hormonal imbalances or certain hormones that may be predisposing women to having an ectopic pregnancy, even if, as you know, when we do IVF, we put the embryo in the uterus, we do it under ultrasound guidance, we take every precaution to put the embryo in the right place, but still, sometimes hormonal levels may be predisposing somebody to have an ectopic pregnancy, and the embryo can literally sort of migrate and implant in the fallopian tube.
Yeah, well, I mean, I think that's a really good finding for people, especially women who've had a history of ectopic. When they're reviewing their IVF options with their physician, especially in those patients, perhaps they should be considering a frozen embryo transfer. Do you think that's something that could help?
Yes, I think so. Even though, statisticians usually look at numbers and say, well, this is in a huge population, but then for an individual patient, it's really a low risk. Well, if that individual patient is my patient, I don't want this to happen again. And so, yes, I think we all have these days a pretty low threshold to do a frozen transfer instead of a fresh, because we have seen that a lot of other OB outcomes, and this is a different topic, but it's kind of within the same topic that we're talking about. The OB outcomes tend to be better with frozen transfers in many ways, and so really. And this, I think it took some time, but then patients also are very savvy and they educate themselves, and they, even though they want to have a transfer the same cycle, sometimes they understand that it may be for the better to wait a month and come back the next cycle and do an embryo transfer, just to try to get a better OB outcome.
Right. And what would happen if you had an ectopic and the diagnosis was missed? What kind of complications can arise from that?
Well, usually this is the way ectopic pregnancies used to present, I think, in the past, probably when there was no good ultrasound, or patients may not be aware that this could be a possibility, but it could be, a lot of bleeding, a belly full of blood, an emergency, hypertension, and of course is life-threatening, really. An ectopic pregnancy is life-threatening, and it has been for many years as the main cause of maternal mortality in the first trimester, particularly in places where there's no good access to ultrasound or frequent labs and close monitoring. Actually, I think the obsession that I have with ectopic pregnancy may have been my very first case when I was an OB/GYN resident was an ectopic pregnancy. It was one of those cases where the patient didn't even remember her last menstrual period. She wasn't sure, that she didn't think that she was pregnant, but she was having pain and feeling hypotensive. And next thing we know, we're in the OR with a belly full of blood and removing a fallopian tube.
Wow, so you literally saved her life, literally. So what I want to do right now is get into a little bit of fertility, or I should say ectopic myth busting, because there's so many myths out there about this. So here I go. Truth or myth? Is that okay with you?
Yeah, of course.
Okay, here we go.
Fun.
A woman who has a blocked fallopian tube cannot get pregnant with IVF. Truth or myth?
Of course, that's a myth. Well, IVF, I always tell patients when patients present with fallopian tube issues, I'm like, IVF was created for you. That's what it is. Tubal infertility is really the perfect patient for IVF. So yes, sometimes if there has been an issue in the fallopian tubes or inflammation for a long time, there could be fluid could accumulate, and then in that case we may remove the fallopian tube before we put an embryo there. That's another thing. But really, fallopian tubes are not needed for IVF, and so usually these are patients that they have a pretty good results with IVF actually.
Okay. So next one, truth or myth? You can't get an ectopic pregnancy after IVF because you don't need the tubes when you do IVF. I know. It's just, yeah, it doesn't make sense, but it's possible. Of course, if you have a tubal ligation, then those are the patients who usually, can say yes, you have very close to 0 chance that you will have an ectopic pregnancy. But yes, that's a myth too. Okay. Here's another one. If your HCG is over 1500. And what that means for those of you who don't know, that's kind of the zone, we call it the discriminatory zone, where you can see a pregnancy most likely in the uterus. And a pregnancy is not seen in the uterus. It's always an ectopic pregnancy. Truth or myth?
You have all myth, Amy. So really, the concept of the discriminatory zone is something that we had for some time, and we still have it, but it has changed over time because the resolution of ultrasound has changed, and then also we have learned things over time. And so it used to be, what it means is like above certain level of the quant of the hormone of pregnancy, you have to see a gestational sac in the uterus. And so that is the usefulness of having a level or a correlation between the quant and the ultrasound. But no, the discriminatory zone has been moved upwards a little bit because safety first, we want to make sure that we really, particularly in a patient who is stable, that we really wait and see how events go. And we first determine that it's a non-viable pregnancy before we move on to possible treatments.
Right, so it could be a viable, but it could also be a miscarriage or abnormal pregnancy growing in the uterus as well. Yeah.
Exactly. So it's important that's when all the measurements and the repeat lab testing and the repeat ultrasound comes, when we really are trying to make sure that there's not an IUP in intrauterine pregnancy in the uterus.
Yeah, and looking at progesterone levels too. So progesterone can also be another test that guides us. If the progesterone level is really low, under 3, for example, it could be a sign that it's almost always an ectopic. Okay, here's the next one. If your HCG is rising normally, it can't be an ectopic pregnancy. Truth or myth?
Well, it's also a myth, and really, it's amazing how sometimes, we have a patient who's perfectly rising quants, and then, an ectopic happens. So at the same time, the opposite is also true. Sometimes the quant maybe it's not duplicating it's not raising as perfectly, but then, then you go with ultrasound, and if, you have to do the assessment and find that sac.
Yeah.
So there's another situation where it's a transient situation, hopefully, but where we have what we call a pregnancy of unknown location, and sometimes that happens too. And that occurs during that time when the levels of the hormone of pregnancy has been going up, but we still in ultrasound we don't see a sac anywhere. But of course you are pregnant one way, and so we there are different things to do depending on the levels, and depending also on if there is pain, if there is bleeding, and if we have any dating, so any good information about when the embryo was transferred, or if it is a spontaneous pregnancy, that's when it most likely happen. When we do IVF, of course, we have the advantage that, okay, we know exactly when we put the embryo in the uterus. So that helps a lot.
Yeah, I call pregnancy of unknown location, I call it HCG hell. Because it really is hell for our patients.
It is.
To not know what's going on, all the blood draws, the ultrasounds, it's really devastating. So,
Yeah.
Okay, here we go. Here's our last one. Truth or myth? You can't have a ruptured ectopic pregnancy if your urine pregnancy test is negative.
Well, we don't go with urine test. The urine test, well, yeah, you can do it at home, but then we need to see the hard facts, right? We need to do a quant in a lab. And I always try patients to, when we are following those quants, try to do it at the same time in the day, in the same lab, just in case. Very important that you follow the actual, results in blood. Yeah.
Yeah, so the blood levels are going to be way more sensitive. Those urine tests don't always pick up the low levels that they can in the blood test, and the low levels are still a sign that you're pregnant and could still have an ectopic. So we definitely don't take anything for granted, and our patient's health is always number one to us. So Laura, thank you for providing expert advice on ectopic pregnancy. Can you tell our audience where they can find you once again?
Oh, sure. Well, thank you so much for having me. I love to talk about ectopic pregnancy. And I practice here in Columbus, Ohio, at Ohio Reproductive Medicine. And I hope to see you soon.
Absolutely. We'd love to have you on. And our next topic together will be ethical considerations with IVF. I look forward to that topic with you. And tell us about your international practice. I imagine you have a lot of international patients as well.
Well, I was pleasantly surprised when I moved to Ohio. I thought there will not be that many patients from other places, and it has been really interesting for me, because I see patients who speak Spanish, which I'm very comfortable with, of course, patients from other countries, and so it has been really great. And also because it's always an interesting aspect of what we do, to see how culturally different patients, how they approach the building of a family, and the different views and wishes that they have. And so that is something that I really enjoy. And so, yeah.
Yeah, good. Well, thank you again. And for everyone who's listening or watching, thank you for joining the Egg Whisperer Show. If you haven't subscribed yet on YouTube, please click subscribe. And if you haven't taken a class yet, go to eggwhispererschool.com and either take my Tushy class or the next IVF class. Have a great day, everybody, and we'll see you back here again soon. Bye-bye.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Abazadeh.
And you have yet another success story.
Just launched by an East Bay fertility doctor.